Clinical use of blood products. Principle: blood products should be used in the following circumstances. Replacement of something that the patient does not have, e.g. factor VIII for treatment in hemophilia A. Replacement of something that is lost or decreased, e.g. correction of anemia or platelets for thrombocytopenia post-chemotherapy. To decrease the problems associated with exposure to a previously unseen antigen, e.g. anti-D in Rh-negative pregnant women or specific immunoglobulin after exposure to infection. Indications: wherever possible, national and local guidelines should be followed. Each NHS trust should supply you with these, often in the form of the Junior Doctor's Handbook. Special requirements exist for the transfusion of products in some patients, e.g. cytomegalovirus, CMV, negative and irradiated blood. All blood products are now leukocyte depleted at source in view of the theoretical risk of transmission of variant Creutzfeldt-Jakob disease. Irradiated blood products such as platelets are used in patients with Hodgkin's disease, those receiving stem cell transplant therapy, patients receiving purine analogues like fludarabine, or profoundly immunocompromised patients. Blood transfusion has received a lot of political interest recently. Packed red cells. It is impossible to provide a trigger hemoglobin, HB, for transfusion that would be appropriate in all cases, in view of the numerous confounding factors that may coexist, e.g. age and systemic disease. Anemia due to hematinic deficiency should not be transfused but the relevant hematinic replaced. There is no doubt that the appropriate transfusion can be life-saving, but it is also clear that a large number of patients are exposed to blood transfusions unnecessarily. Recent studies have suggested that patients whose HB is allowed to fall to around 8G/DL may have a more favorable outcome than those transfused with higher HB values. The number of units to be transfused depends on the clinical situation and the HB. Blood conservation mechanisms should be explored, and recombinant human erythropoietin may reduce or prevent transfusion requirements in carefully selected patients who have anemia due to cancer or other systemic chronic illness. Timely preoperative assessment clinics, at least 4 weeks before elective surgery, with judicious use of iron, orally or parenterally, may lead to less usage of packed red cells in surgery. Platelets. Once again, strict criteria cannot be applied to all clinical situations. Platelets should be given if the patient is bleeding and the platelet count is 50/100x109/L, for example patients who have received massive transfusions and in the setting of disseminated intravascular coagulation, DIC. The maximum increment that can be expected following 1 dose of platelets is 40x109/L, pooled from 4 donor units. Usually only 1 dose of platelets is given at a time. Prophylactic platelets are given to patients with counts below 10x109/L to reduce the risk of spontaneous hemorrhage. Fresh frozen plasma. Definite indications are acute DIC, thrombotic thrombocytopenic purpura, and the replacement of a single coagulation factor deficiency if the specific concentrate is not available. Conditional uses arise in liver disease or a massive transfusion associated with bleeding and abnormal coagulation tests. The dose of fresh frozen plasma, FFP, is 12-15 ml/kg, this is usually 3-4 units. Substantial bleeding in patients on warfarin should now be treated with a prothrombin complex concentrate rather than FFP. Cryoprecipitate. The chief indication is for the replacement of fibrinogen, e.g. DIC, hypofibrinogenemia, or dysfibrinogenemia. The dose of cryoprecipitate is 10 units given intravenously. The fibrinogen level should be greater than 1 G/L in these situations. Immunoglobulins, intravenous or intramuscular. These are used for patients who have inherited or acquired deficiencies of gamma globulins such as chronic lymphatic leukemia or severe combined immunodeficiency, in people exposed to infections, e.g. hepatitis A or B, and in certain diseases thought to have an immune component, e.g. immune thrombocytopenic purpura and Kawasaki disease. Albumin. Treatment with albumin is controversial and operator-dependent. Some anesthetists insist on albumin as a plasma expander. Anti-D immunoglobulin. This is given to Rhd-negative women when there is a risk that Rhd-positive fetal cells may enter the maternal circulation, thus causing the mother to become immunized with a possibility of hemolytic disease of the newborn in subsequent pregnancies. It is given prophylactically in the third trimester, as well as within 72 hours of any sensitizing event, e.g. delivery, abortion, or amniocentesis. Contraindications. Blood products should not be used outside the recommended indications unless discussed with the hematologist. Blood products should never be used simply for volume expansion except in the context of hemorrhage or significant anemia. Practical details. NB. The most important aspect of blood transfusion relates to complications due to administration errors. Before treatment, the blood sample for cross-matching must be taken from a patient with an armband, who is identified by you as the correct person. The blood sample must then be labeled by you at the patient's bedside. Prelabeling of tubes is completely unacceptable due to the high error rate. There should be at least 3 independent identifiers on the bottle and the form, such as name and surname, date of birth and hospital number. Laboratory work. The patient's blood is grouped, ABO and rhesus, and serum screened for antibodies. A cross-match is not routinely carried out for patients who have not received any transfusions or for those who have no antibodies. The blood grouping is established and an antibody screen is carried out. If the screen is negative, blood can be issued electronically, i.e. without physically mixing the patient's serum with prospective donor cells. Patients with a positive direct antiglobulin test will have a cross-match carried out. In a routine cross-match, the patient's serum is mixed with red cells from the prospective donor units, looking for cell aggregation due to antibodies, incompatibility. Compatible units are then labeled with the patient's details and set aside in the refrigerator for use. The treatment. A qualified person, who has a written request form containing the patient's details, must fetch the cross-matched products from the blood fridge. 2 qualified members of staff on the ward must check the blood products at the patient's bedside with the patient's details. There are moves towards an electronic patient identification system that uses a barcode attached to the patient's wrist and matches it with the number on the unit of blood component to be transfused. The information on the armband must exactly match that on the blood bags, the drug chart and the information provided by the transfusion laboratory before transfusion can take place. Ensure that the correct armband is on the correct patient. Complications. The most frequent complication reported to the shot, serious hazards of transfusion, committee is where a patient has received blood components intended for someone else. About 2/3 of these involved one or more error, due to deviation from the guidelines mentioned above. An incompatible blood transfusion may result in few adverse effects or may cause an acute fatal reaction. Other complications include allergic reactions due to platelets or white cells, febrile reactions to human leukocyte antibodies or plasma proteins, circulatory overload, transfusion-transmitted infections, e.g. hepatitis C, HIV, malaria, and CMV, graft vs host disease, transfusion-related acute lung injury due to FFP, immune sensitization, e.g. to Rhd antigen. Reactions due to bacterial infection of products. Clotting abnormalities, in massive transfusions.